I wanted to really focus on two major topics, and that is the problem of urinary control in men and the problem of erectile dysfunction. How to tie these two subjects together. And I recognize that prostate cancer is frequently associated with these diagnoses. I'll share with you how, and I'll tell you some things that we've learned that can help us deal with these problems. We're going to deal with the subject of urinary incontinence. Let's figure out how the system works. These are the kidneys. Tubes that lead the urine to the bladder are called the ureters. The bladder, in this case the prostate, sphincteric mechanism, or the shutoff valve. The tube that goes from the bladder to the outside is called the urethra. With the prostate in place, the bladder has a very definite position within the pelvis, and it is supported there in large by the prostate. The bladder has some unique characteristics. It has what we call compliance, and compliance means that the muscle fibers in the bladder slide one over the other. The bladder can increase in capacity without having pressure within the bladder increased. When the sphincter mechanism is appropriately functional, the sphincter tends to remain closed until there are signals for it to open. There's a large number of men who are diagnosed with prostate cancer each year. And equally important, there's a very large number of men who have prostate surgery for treatment of that cancer each year. About a minimum of 10% have an element of incontinence, and really that number can go as high as 65%. Now, what about prostate cancer causes incontinence? Nothing. It's a treatment. There's a number of very fine nerves and vessels that are associated with the prostate, and surgical removal is the problem. Prostatectomy. Now, the idea is to keep that complication rate very low. The reality is statistics are what they are and say what they say. A robotic prostatectomy is nothing more than a radical prostatectomy done through a number of incisions with a laparoscope with computer assistance. What this instrument does is give the surgeon more control over the instrumentation and to a degree improves his vision. Radical prostatectomy for prostate cancer is known as a gold standard, but that's changing. That women will know the term radical mastectomy very well. You hardly hear that term anymore, and it's been replaced by lumpectomy, which is minimally invasive treatment for breast cancer. Folks, minimally invasive treatment for prostate cancer is not only just around the corner, it's actually here. What about treatment? Well, we want to, of course, get rid of the frustration and embarrassment of, in this case, being wet, depression and anger. And what we want to do is restore quality of life. Management means we're resigned to living with the problem. How can we deal with that best? Can we do better? Treatment seeks to relieve the problem, collagen, maintain that ever youthful look. We can inject that collagen in the area where the sphincter is to make the sphincter work a little more efficient. Think of that leaky faucet when you took it apart and there was this washer in there that was all ground up, and you put a new washer in, you put it in, and by gosh, the faucet turns off and the water doesn't leak. We try to do that with collagen to the sphincter. The most common type of incontinence is stress incontinence, which means if you have a full bladder and you cough, sneeze, strain, oops, leaks. There is a device called a sling. Now, slings were first utilized for women, and slings support the bladder in a position that the normal shutoff valves and muscles can work. Simple solution for a complicated problem. There are more severe kinds of urinary incontinence. There's literally the leaky faucet when the sphincter or the shutoff valve mechanism doesn't come together properly. This is called the artificial urinary sphincter. I was involved in its development. I worked with a gentleman in Houston, Texas. His name was Brantley Scott. The cuff goes around the urethra, the pump is in the scrotum, and the reservoir is in the abdomen, totally concealed. And the artificial sphincter now has been implanted in patients who have incontinence dating back to the mid-1970s. And I think I implanted the first one in this part of the country in 1977. Here's the device without the clutter of the anatomy. Here it is in action. The bladder's full. You want to be dry. The cuff's inflated. It's time to void. The bladder's telling you it's full. You pump the fluid out of the cuff into the reservoir. The cuff opens. You can void in just the normal fashion. And after about 180 seconds, the balloon or the reservoir will push its fluid beyond the delay fill resistor, refill the cuff, and increase the pressure in the cuff, creating continence. So there you have it. You don't have to be wet. Erection dysfunction. Well, what is it? What can we do about it? Well, first off, it's the inability to be able to become aroused as a man and not have the ability to have a full erection or an erection at all. It can be just brief enough to get the person who has the problem disgusted and discouraged and depressed, and they just avoid the subject of sex. So how does an erection occur? Mother Nature built in a system. Here's what happens. Some type of stimulation sets that system off. All of a sudden the heart rate changes, the blood pressure changes, the hormone contents change, and in the process the blood flow to the penis increases. The little muscles that make up the erectile tissue tend to relax, and the erectile tissue engorges with blood and produces an erection that is firm enough for intercourse. At some point when that stimulus is no longer present, this whole process just quietly resolves. I think it's important to recognize that between the ages of 40 and 70, about 50% of men, 50%, half, have some element of this problem, minor to complete. Cialis, Viagra. These are known as 5-phosphodiesterase inhibitors, just a chemical name. And what it does is it brings about that chemistry that allows the increase of blood flow, relaxation of the muscles, engorgement, erection, and the kinds of things that go with the mechanical aspects of sexual arousal or erection for men. In some situations, you actually have to have a higher concentration of medication to really make it work. So needle injection of a different preparation, but really the same basic chemistry into the erectile tissue, known as injection therapy, is a popular and very efficient therapy. So this is an overview of the treatments. Here's injection therapy. Now this is the suppository system that we can put into the urethra, and this is a vacuum device, which works very well, by the way. Works very well, by the way. Most people who have erection dysfunction can get first-class erection with a vacuum device. And I've had a number of patients that have taken these and been happy with them initially. But the usual story is this: Doc, you know that thing you gave me or told me to get works, but by the time I get the job done, I forget why I did it. Here's a malleable prosthesis in the erectile body, and you can flex it to the erect position as I showed you, or push it down to the less than erect position. Now this is an inflatable prosthesis, It's not the one that I use most frequently, but certainly have used. And it has a pump in the scrotum and inflatable cylinders. And when you pump this pump, you inflate the cylinder and you can create a good quality erection. And the advantage is when you release the erection, the fluid goes back into this reservoir and the penis detumesces or becomes soft. My personal view, though, is this three-piece prosthesis is probably the best. We put the reservoir in the abdomen, the pump in the scrotum, and the cylinders in the erectile tissue. And then this pump mechanism allows the shift of fluid from the reservoir into the erectile cylinders and can give a good quality erection. The thing about it is when you let the fluid out and put it back in the reservoir, the penis feels very normal. It's soft and it's God-given, I think is the way to say it. So it's a unique and very good solution. Satisfaction rates are high. Reliability is better than 90%. I think the best testimony to its quality, though, is the patients. 96% of patients surveyed say they do it again. Well over 90% have recommended this type of treatment option to their friends. It's covered by most insurance. Medicare covers it, sort of sets the standard. There's another form of erection dysfunction. It's called Peyronie's disease. It's named after a physician who really described it back in the 1800s. The more severe cases of Peyronie's actually impair the flow of blood into the erectile bodies, and the distal portion of the penis doesn't become erect. You can use an inflatable prosthesis, and in those circumstances you can correct the curvature and you can give them the capacity to recover their erectile function. There's a traction system that we have that we can use for Peyronie's disease, and in the less severe cases we can actually straighten the curvature simply by using the traction device. We usually do other things along with that. There's a medication called verapamil that you can inject into the Peyronie's scar tissue or the Peyronie's plaque. BD is common. We have good treatments for all types and for most patients. You know the story. It's up to you. Take action.